Thank you, folks. It's a pleasure to be here addressing you. I'm going to talk about how American healthcare compares to healthcare and health in other wealthy countries. My lecture is going to break down into three sections, basically: an overview of American healthcare in comparison to the other wealthy nations. We'll talk about how things started to change in the early 1980s and what drove American healthcare off the rails. So it's extremely expensive, and yet Americans are extremely unhealthy in comparison to the citizens of the other wealthy countries. And then finally, I want to talk about what we can do to fix it. And these are deep problems, and there aren't quick fixes, but we'll talk about that. So first, an overview of American healthcare. There's three ways to compare the health of populations. The quickest way, and the one most frequently used, is life expectancy. That takes the current mortality rate at each year of life at the present and puts that together into a composite picture that projects how long current Americans are going to live. The second way to do it, which is far more dimensional, is healthy life expectancy, which is the number of years, not that we live in toto, but that we live in good health. And years of disease are prorated. So if somebody lives to be 86, but they had chronic renal failure, say, for 6 years, starting at age 80, and that compromised the quality of their life by 50%, then their healthy life expectancy would be measured at 83, half of the 6 years. And then finally, the most accurate way to compare countries is on age-adjusted mortality rates. And the reason why that's more accurate is because different countries have different average age in the population. And the older a population is, the higher the mortality rate is. So age-adjusted mortality rates correct for the differences, the age differences in populations, and ensure that those comparisons are accurate. So first, life expectancy compared to other wealthy nations. Okay, I'm sorry. The slides before this weren't visually important. So this is the first way to compare countries, life expectancy in the U.S. compared to other wealthy countries. And you can see that back around 1982, when I first went into medical practice as a family physician, the United States was pretty close to the average of 10 other countries. But as time went on, the curves separated, and longevity in the United States fell further and further behind the other countries. So that by the time we got to 2019, which is an important landmark because that's before the COVID pandemic started, and the data aren't distorted by COVID. When we got to 2019, Americans were living 3.8 years less than the citizens in the other countries. And then when we get to 2022, we've lost even more years of life, and we now live 4.7 years less than the citizens in the other wealthy countries. But if we turn to healthy life expectancy, the Americans' healthy life expectancy has fallen from 38th in the world in 2000 to a tie for 68th in 2019. Citizens of Japan now live 8 years longer in good health, and Canadians 5.2 years longer in good health than Americans. And it's particularly informative to look at how we are doing compared to China in healthy life expectancy. In 2000, these four data points go from 2000 up to 2019 for both the United States and China. And you can see in 2000, Americans lived 2.1 years more in good health than the Chinese did. But by the time we get to 2019, Chinese are living 2.4 years longer than we are. And this is particularly informative because between 2010 and 2019, the healthy life expectancy of Americans actually went down from 66.7 years to 66.1 years. It went down. It went down by 0.6 years. During those 10 years, there's only 3 other countries in the world whose life expectancy went down more than Americans. Those 3 countries are Syria, Yemen, and Venezuela. Now, that is not good company to be in. So this is a real crisis. And as China was gaining on life expectancy, so it surpassed us by as much as we surpassed them, but more than we surpassed them in 2000. China's in 2019 was spending $11,582. Excuse me, the United States was spending more than $11,000 and China was spending $540. In other words, we're spending like 20 times as much as China is to achieve these inferior results. And then if we go to the third way to compare health between countries, the age-adjusted mortality rates. In this chart, we see 1980 to 2020, and you see the excess deaths of Americans in comparison to the citizens of the other wealthy countries based on age-adjusted mortality rates. And you can see in 1980, in the early 80s, Americans actually were doing better. There were fewer excess deaths in the United States. In 1982, 50,000 fewer Americans died than would have been predicted by the age-adjusted mortality rate in the average of the other countries. But by the time we got to 2019 actually here, by the time we got to 2019, before COVID started, there were 622,000 excess American deaths each year compared to the citizens of the other wealthy countries. And then if we go to 2021, we see that the excess mortality rate has leapt up again, so that 1.1 million Americans are in excess, are dying compared to the citizens of the other wealthy nations. Now, 1.1 million deaths a year is equivalent to 3,000 deaths every day. It's like a 9/11 disaster every single day of the year in, year out. This should be front page news. I mean, the 9/11 disaster changed the course of American history. And yet this is going on and it's not getting any press coverage at all. It's hard to get this out into the media. It's really alternative media that's willing to cover this. But the important fact here is that, well, 1.1 million Americans in excess are dying each year. We are paying in the United States over $12,500 per year, while the citizens of comparable countries are spending half that much. And if you look at that, if you subtract what we are spending in the United States from what the other countries are spending, that's $5,900 per person per year, and you multiply the $5,900 times the population of the United States, 334 million people, you see that we are spending $2 trillion a year, $2 trillion a year in excess of the other countries, while 1.1 million Americans are dying in excess each year. It's craziness. Now, to put $2 trillion in perspective, the annual US budget deficit, which is enough to create political crises about funding the government, is $1.73 trillion a year. It's less than we're wasting each year on healthcare. $2 trillion is about 2.5 times our annual military budget that we're wasting. And it's almost as much as the total global military spending. That's $2.2 trillion a year. So this is an enormous amount of money that we are wasting in the United States to achieve horrendously inferior health for the American people. If we look at the function of the American healthcare system, this is a study that compared the access to care, the process of care, administrative efficiency, equity, and healthcare outcomes in 10 countries. And here we have higher system performance and lower system performance. And here we have higher spending as a percentage of GDP and lower spending as a percentage of GDP. And we see that these 10 countries group quite tightly in terms of the percentage of their GDP they spend on healthcare and the performance of their systems. Excuse me. But the United States isn't on this graph yet, because this is where the United States is. We're totally an outlier in both cost and spending and function of the American healthcare system. So the question is, how did we get here? This is a disastrous place to be. We talk about national priorities, and there's 1.1 million excess Americans dying each year, and we're wasting $2 trillion. Now, sometimes we think, well, that's other people. That's people who don't look like us. That's people who aren't wealthy, they're poor. But that's not us, because those of us who are privileged in this society, we can escape that, because it's just a matter of poverty or racism or sexism, whatever. But that's not the case. This is a study that was published in JAMA, and it compared in this comparative effectiveness study of 6 health outcomes, white US citizens in the 1% and 5% highest income counties. So these are the most privileged folks, obtained better health outcomes than average US citizens, but had worse outcomes for infant and maternal mortality, colon cancer, childhood acute lymphocytic leukemia, and acute myocardial infarction, compared with the average citizens of other developed countries. In other words, the most privileged Americans, the wealthiest, the whitest cohort of Americans, has worse health than the average citizens in the other developed countries, which are spending $2 trillion a year less. And we're going to see as we go on that most of our health is not determined by the healthcare we get, but by the environment we live in and the social determinants of health, housing and education and income and so forth. And it's those issues that account for most of the difference in the health between the United States and the other wealthy countries. So now we turn to the question, how did we become such an outlier? We were doing fine up until the early 80s. We were actually on age-adjusted mortality rates, we were actually doing better than the other countries. We were spending a little bit more, but not very much more. So how did we become such an outlier? And this, the next 2 slides are from an article that was published in the journal Science in 1982. You can see in the small print down here. And this article marked the pivot point where the United States turned from a country that had decent health care for a reasonable price to a completely dysfunctional healthcare system. And this is important to me because I was a Robert Wood Johnson Fellow from 1980 to 82. I was studying statistics and research design and epidemiology and analyzing the journals critically for misrepresentations of data and so forth. And at that point in time, commercial influence was not playing a role in what the journals were presenting. However, we were right at the point when things were going to change. And this article from the journal Science says grants from the National Institutes of Health and the National Science Foundation are fewer in number and harder to get. For universities to turn to alternative sources of research support is not only prudent, but downright essential. And it was especially essential, not just because the percentage of grants that were getting funded went down, but it was especially essential because managed care was just starting to play a role in the reimbursement of academic medical centers and hospitals. And the academic medical centers were getting squeezed at just the time the federal support of research was going down. So this created quite a problem. And what happened is This is a quote from the article in Science. Scientists who 10 years ago would have snubbed their academic noses at industrial money now eagerly seek it out. So when I was in medical school, I started medical school in 1972. It was rare that a doctor had a financial tie to a drug company, and it was not looked upon as a status symbol or a badge of prestige. It was looked upon as commercialism. But as the situation changed and the academics needed to turn to commercial support, they started to, as Barbara Culleton said, eagerly seek it out. Now, another thing happened at just about the same time. The Bayh-Dole Act came in. I'm old enough to remember when imported Japanese cars were a novelty, when everybody drove American cars, everybody who wasn't eccentric drove American cars. But the Bayh-Dole Act was passed, and that was passed because the federal government was funding research, but the people and institutions that did the research couldn't benefit from commercializing that research. So many of the patents that were developed with federal grants were lying fallow in file cabinets and not being brought to the market so that the discoveries could benefit Americans. So the Bayh-Dole Act was an attempt to rectify that. Nonprofit research institutions were drawn into the commercial realm by the passage of the University and Small Business Patent Procedures Act of 1980, Bayh-Dole. This legislation allowed nonprofit research institutions to commercialize discoveries made by their scientists while conducting federally funded research and to retain any profits derived from those discoveries. Now, recently, we've had an enormously dramatic example of that, where the NIH developed the technology to make mRNA vaccines very quickly once the genetic code of the virus was provided. That was done in 2016. And when the COVID epidemic came along, Moderna used that research and used federal support of further research to develop its COVID vaccine. Now that is the system, that part of the system is working. COVID vaccines were developed early on. The United States had the Operation Warp Speed that was presented by President Trump. And I agree with what he did. He just threw money at the problem to try and get vaccines out as quickly as possible. And Moderna was very happy to take the money. So the bottom line here is that Moderna made a fortune. Moderna's CEO is now worth almost $4 billion. And that $4 billion is basically comes from the federal funding of the infrastructure research of developing the mRNA vaccines, and then the federally funded research to develop the COVID vaccines. So now we've got scientists who are able to become enormously wealthy, far wealthier than they need to be to motivate their scientific discoveries. And what's happened is that the universities themselves they've been taken into the marketplace, and much of what they do is determined by how profitable their activities are. So in 1981, Derek Bok was president of Harvard University, and he was reflecting on this potential commercialization of universities and wrote in Harvard Magazine that there was developing an uneasy sense that programs to exploit technological development are likely to confuse the university's central commitment to the pursuit of knowledge, that the money will confuse the university's commitment to the pursuit of knowledge. And I would like to add to that, and I assume that President Bok would agree, it's not just a university's central commitment to the pursuit of knowledge, but universities are tax-free institutions, and they also have a commitment to knowledge that's produced for the public good. And what President Bok was saying is he's worried that that public commitment is going to be displaced by the financial opportunities. So this is the context in which our medical knowledge is now being produced. And I want to ask two questions about that medical knowledge. And the answer to those two questions is imperative to figure out why we've dug ourselves into such a deep hole. And you can't understand what's going on here. It's not, the answers aren't simple, that drug companies are greedy, that insurance companies game the system, and so forth. Those are problems, but those aren't the core problems. And we have trouble fixing those problems, but we're not going to fix American healthcare until we get to the core problems. So question number one is the new medical knowledge that informs healthcare professionals and policymakers epidemiologically balanced? In other words, is that knowledge produced, is the research funded, and is the knowledge produced in order to create new knowledge that will best promote, improve the health of Americans? Is it a public health market that's funding this research, or is it a commercial market? Is that knowledge funded, produced, and disseminated in order to make money for commercial players? And what we find out, I think you can guess what the answer is, but what we find out from an article from JAMA called The Anatomy of Medical Research, this data I think is from 2013 or 12, the United States spends $116 billion annually on research directed at new drugs and medical devices, but only $5 billion aimed at health services research, which examines access to care, quality and cost of care, the health and well-being of individuals, communities, and populations. Exactly the things that were measured in that graph I showed just minutes ago that showed how the United States was failing in comparison to the other countries to have a well-functioning healthcare system. Well, why are we spending 96% of our research money in drugs and devices and only 4% on population health and primary care and health systems that work more effectively and efficiently? The answer is obvious. One major difference is that new drugs and devices command favorable prices, and their value accrues directly to the firm that invests in them. In contrast, service innovations that can reduce morbidity and mortality, and let me broaden this to include service innovations, but this would include the social determinants of health, research on the social determinants of health that can reduce morbidity and mortality while also reducing cost. But the financial returns from such research the financial returns based on that research is going to be not only negligible, but most likely negative. Because when we look at the social determinants of health, which will in a minute, we would find that much of the health that we're trying to improve is best improved by changes in how we live our lives, not by drugs. And if we look at the most widely prescribed class of drugs in the United States, it's statins to lower cholesterol. And we can talk about this in the question and answer session, but statins may reduce the risk of cardiovascular disease by 20%. But lifestyle modification reduces the risk of cardiovascular disease by 80%. Yet there's never been a study funded, because the statin makers fund the studies, there's never been a study funded that compared statin therapy to reduce cardiovascular disease, the risk of cardiovascular disease, to lifestyle modification to reduce the risk of cardiovascular disease. There's never been a study that asked that question. Why? Because of what you're looking at on this slide. The financial returns to be negligible or even negative. And what we have is a commercial market-driven system of producing the knowledge that informs our healthcare system. We don't have a public health-driven market to inform our healthcare system. Let's look at how, let me get it. Let's look at how this plays out, for example, in the growing prevalence of type 2 diabetes in the United States. This data is from 2007 to 2020. And if we start here in 2007 and go up to 2020, there's a 42% increase in the number of people who have type 2 diabetes. And as Pam Popper was saying in the last lecture, this is not complicated. It's because Americans are taking in more calories and they're not physically active enough to burn off those calories, and their weight is going up. As we see here, the obesity rate in the United States in the late 70s was 15%, and now it's 45%. So the obesity rate in the United States has gone up 3 times since the late 70s. 3 times. Now, our genes didn't change during those years since the late 1970s. What changed is the way we live our lives. But the research that's done is looking for money, it's looking for profits, it's not looking to improve health. So what our market does is it develops weight loss drugs for diabetic and non-diabetic patients. And instead of getting at the core problem, which is we're not getting enough exercise and we're taking in too many calories, what we see is that we're rapidly adopting the weight loss drugs, diabetic weight loss drugs, to solve this problem. We're solving it the wrong way. Now we've got in 2022, we had 5 million prescriptions of these weight loss drugs being written a year. It's about $1,000 a pop. So we're talking about $5 billion invested in weight loss drugs, the long-term effect of which we don't know, except we do know that when people stop taking them, they're going to gain all the weight back. And what we're doing is solving a social problem of not exercising enough and taking in too many calories with a drug, and that drug is going to have a side effect. It has to have, it has side effects with gut and nausea and so forth. But long term, nobody knows what the solution is going to do, but it's the wrong solution for the problem. And this is a perfect example of how the United States healthcare system got off track. Now, to fuel our going off track, let's compare the prices of weight loss drugs. Look at the top line, and you see in the United States, the 4 weight loss drugs cost about $1,000 a month. But look at the next line. In Japan, instead of Ozempic costing $936, it costs $169. And it costs even less per month in the other countries. It goes down to $83 in France. And the other drugs are far less as well. So part of the problem, when we think of high drug costs, we think of taking money out of the system, and it does, and that's a very serious problem. And that money could be reinvested properly in helping people to become healthy and to adopt healthy habits. But what we see is that in the United States, the profits are so high on these drugs, it doesn't cost any less to produce these drugs in the other countries. So this is all the difference between the United States and the other countries is sheer profit. It doesn't cost any less. So what we're seeing is that this enormous profitability, this way out of line profitability, is what pulls our system into the solutions that are most lucrative, not the most healthy, not addressing the problem at its root cause of how much exercise we get and how many calories we ingest. So the high cost of drugs not only just rips money out of American society, but it distorts our healthcare. And in fact, between 2/3 and 3/4 of the profits, of the global profits from pharmaceutical companies, come from the United States. So this is a major issue that distorts our healthcare. The second issue, that's the first issue, is our scientific evidence, is the evidence that doctors rely on as evidence-based medicine. Is it epidemiologically balanced so that it informs the doctors how best to help their patients achieve or maintain health? That's question number one. We're failing on that. Question number two is the non-transparency of clinical trial data. Is the scientific evidence derived from clinical trials accurate and reasonably complete? And the conventional wisdom that most, if not almost all doctors believe, is that the scientific evidence that we docs get, that we are taught to adopt as credible knowledge and implement in our patient care, that scientific knowledge, that the science that we read in our medical journals has been peer reviewed. And the peer reviewers have examined the data and have reviewed the study and the analysis of the study, and they've signed off. They've given their seal of approval to the report of the clinical trial before it's ever published. But it's not so simple as that. What the doctors can see, this is a schematic drawing, and this is a good doctor. He's got his doctor bag and his rowboat, and his rowboat is named Scientific Evidence. It's very romantic. And he's looking with his telescope at the publicly available information upon which he or she is going to base his or her decisions about how to take care of their patients. And what are they looking at? They're looking at peer-reviewed journal articles. They're looking at clinical practice guidelines. They are, we must be honest, looking at drug company marketing. And that basically, that's what the public information is comprised of. And that doctor in his rowboat titled Scientific Evidence believes he's seeing the scientific evidence, but he's looking at an iceberg. And he's not looking at what's under the water, beneath the water line in the iceberg, because that's where the real information is. Down here, we see reams of paper, file cabinets full of paper that are collected in clinical trials, where the results of each patient visit are recorded and stored and then turned into electronic patient-level data sets so that they can be manipulated and searched electronically. And then those electronic patient-level data sets are turned into clinical study reports, which present the tabulated data from the electronic patient-level data sets into the outcome measures and the safety measures that are pre-specified in the protocols for the clinical study. These clinical study reports are between 1,000 and 3,000 pages long. And I spent over 10 years in litigation in big national pharmaceutical litigation against the pharmaceutical companies for misrepresenting or not representing the harms of the drugs and misrepresenting the efficacy of drugs. And the first thing I would go to as an expert in litigation would be the clinical study report. And I want to say parenthetically that when I was in litigation, I would get access to about 20 million documents in each case. As an expert, I had to sign a confidentiality agreement, but I got access to the executives and the science, the leaders in science and the marketing leaders in each company that was being sued. I got access to their hard drives, their computer hard drives. And as an expert in litigation, I could figure out what was actually going on. And this is an enormously privileged position that doctors don't have the opportunity to have unless their career drifts in the direction of being an expert in litigation. But I could figure out what was going on. And when I was an unpaid consultant to the FBI and the Department of Justice, I had figured out in civil litigation what an arthritis drug, how an arthritis drug had covered up, or the manufacturer of an arthritis drug had covered up the risk of the drug causing cardiovascular events, like Vioxx. It's a cousin of Vioxx. I figured that out, but I couldn't tell anybody because the suit was settled. And when a lawsuit is settled with a pharmaceutical company, the data gets sealed. They can't be made public. They're not made public. So the data is sealed. So I knew what was going on, but I couldn't make it public. But I decided that this was so important that I would pick up the phone and call the Department of Justice blind and tell them that I knew a lot about this drug but I couldn't tell them unless I was subpoenaed. So a few days later, a federal marshal came out to deliver a federal subpoena to tell me that I would be at FBI headquarters and I would bring my computer and I would share what I knew about the drug. And when I went to FBI headquarters at the appointed time, um, there were FBI agents, there were FBI lawyers, there were Department of Justice lawyers, and there were Department of Justice lawyers in Washington on speakerphone. And they interviewed me for about 4 hours and they asked me really tough questions. They wanted to make sure what I was saying was defensible and that I had the documents. Now I was under subpoena, so I could show them the documents and show them my analyses. And they listened well and they said, thank you very much. And I heard nothing more after that until about 6 months later, when I read in the newspaper that the drug company had had pled guilty to a felony and settled on a fine of $1.195 billion. It was the largest fine in the history, criminal fine in the history of the United States for any matter. But still, the data remains settled, and still I can't share the data. So money changed hands. But the really important goal that I wanted to achieve was to inform doctors and the public about how they were being deceived when they couldn't see they couldn't see the iceberg under the water and they couldn't see the real data. And people who were able to couldn't do independent analyses of this data and show that the cardiovascular risk was significant in this drug, and the drug company had failed to report it. So the initial response of docs is, well, we read our journals, and I'm a smart man or woman, and so we read our journals and we keep up to date, and that's how we practice medicine. But in truth, when you look at the actual data from the studies and compare that to what's published in the journals, only 23% of the important outcomes from an average of 23% of the important outcomes of clinical trials that are reported in medical journals, only 23% of the important outcomes are reported in the journal articles. Only 19% of the benefit outcomes and 26% of the harm outcomes. So doctors who think they're performing responsibly as learned intermediaries by reading their journals and looking at the guidelines and participating in continuing education, think that they are able to fulfill their social role as learned intermediaries for their patients and sift through all the scientific evidence and bring their patients the best of scientific medicine. They can't do it. And let me present, I'm sorry, before I get there. So this is the incomplete reporting of harms and benefits in medical journals. And the problem is, this data is from Germany, that only a quarter of the new drugs, 25% of the new drugs that are approved, are actually significantly better than previously available therapy. Only 25%. So you might say, why don't doctors just pick out the 25% that are most effective if they read their journals? But we just learned that the journals aren't reporting it. And in fact, it's going in the other direction. This is a very clever study that looked at the association between the efficacy of drugs and manufacturer spending on marketing. And what this study found is that they looked at 135 studies for which they had data. A third of the studies showed high added clinical benefit, and 2/3 showed a low added clinical benefit. But the key here, there are two keys. Number one is that the drug companies spent 3 times more marketing the low added clinical benefit drugs than they did the high added clinical drugs. And the other point is that in the United States, unlike the other wealthy countries, we don't have an agency of health technology assessment. So the National Institute of Clinical Excellence in the UK, for example, and in Germany and in France and in Canada and all the other wealthy countries. They have independent agencies that evaluate the value of new drugs and make recommendations to the government for coverage and price, and to doctors for which drugs they should prescribe. But in the United States, we don't have such an agency. And sometimes people think, well, the FDA, that's the FDA's job, but it's not. The FDA's job is to approve new medicines or old medicines for new indications, to approve them because at least one study has shown that the drug provides significant benefit and not a counteracting harm, more benefit than harm, and a significant benefit. So the FDA's job is to determine which drugs doctors are allowed to prescribe. But the FDA plays no role in informing doctors which drugs they should prescribe. And in fact, I've been involved in a number of situations where the FDA was fully aware that the results of a clinical trial were published in a medical journal and they were published inaccurately, but the FDA knew it was inaccurate, but they don't correct the mistakes. So they know that doctors are being misinformed and they are the only ones with the data and they don't correct the journals. And the end result of all this is that without a formal mechanism of health technology assessment, US doctors can't identify which new drugs truly provide previously unavailable benefit. That in the United States, we saw how much more expensive the weight loss drugs were in the United States than the other countries. And that extra money, in part, fuels the excessive marketing efforts. You get to see the tip of that iceberg when you watch TV and you're just bombarded with drug ads. Let me add that the word is that whenever a TV segment is bounded by a drug ad, there's not somebody who might be critical of the pharmaceutical industry. So when my first book came out in 2004, and Vioxx was pulled from the market a week thereafter because yet another study showed its cardiovascular risk, and I'll get into that in a bit. But when that book came out, I was all over the TV, national TV, and the media, and op-ed pieces, and coverage in magazines, and so forth. This book that I just published in 2022, I got virtually no coverage on TV. In fact, it's quirky, but the only person who covered me was Tucker Carlson. Obviously, I have some ambivalence about, but he covered me and covered me honestly. But because new drugs are so much more expensive and because marketing is so much less restricted in the United States, new drugs diffuse more quickly, whether they're effective or not. Brand name drugs cost 3.5 times more in the United States than in other OECD countries. And as I said before, 2/3 to 3/4 of global pharmaceutical profits come from the United States because of our marketing, the price of brand name drugs, and the extent of the drug advertising and other marketing that goes on. So let me show you what can happen. This is a true story. I've changed these emails only to protect the identity of the individuals involved. But when my first book came out in 2004 and Vioxx was pulled from the market a week later, I got catapulted onto the national scene and was on the Today Show the next day. I had hardly done any interviews, and suddenly I was on the Today Show. And I got called back on the Today Show about 6 weeks after that because another drug got into trouble. So this is an email I got after the second time I was on the Today Show. It's dated December 2004. And the subject, I haven't changed anything. This is an old email address, so don't try it. But the subject of the email is Vioxx death of 17-year-old. Need your professional opinion. And the text is, Dear Doctor, my name is XXX. I was wondering if you would be willing to review our daughter's autopsy report. It would be a blessing to us. Please help us. My daughter Stacy was 17 years old. The identity is disguised here. My daughter Stacy was 17 years old. She passed away on September 11th, 2004. This is a week before Vioxx was pulled from the market, almost 5 years after Merck knew about its cardiovascular risks, but didn't kept marketing the drug. So my daughter Stacy was 17 years old. She passed away September 11th, 2004. We haven't been able to really get any straight answers in our situation. We would really appreciate any opinions or help you could give our family on this case. Thank you. I mean, this is just heartbreaking. I got to know the mother. We spoke on the phone several times, and just heartbreaking. So let me show you the result of the privatization of medical data and the non-transparency of peer review. That this lady, this young girl, lost her life because of this. This is an email that was written on the day that the Vigor trial, let me backtrack a bit. Vioxx was approved in May of 1999. It was approved for arthritis and pain, but it was not approved for what Merck thought was its primary marketing advantage, that it was more gentle on the stomach and less likely to cause serious GI bleeding and other problems. So Merck, as all the companies do, and it makes perfect sense, I'm not being critical, Merck got the drug approved based on its efficacy for treating arthritis and pain, and saved the study, the safety study, that would show that, would hopefully show that it was safer than the other non-specific anti-inflammatory drugs like Advil or naproxen, and so forth. They saved that study for later. They wanted to get their drug approved on the market. And then they did a study called the Vigor study, gastrointestinal outcomes research study. And when a study is done, it's double-blinded, and the company executives aren't allowed to look at the data until the study is complete. And then the study can be unblinded, because unblinding it and knowing who took which drug won't affect the results. So the Vioxx had been approved and went on sale in the United States in May 1999. In March of 2000, the Vigor study of gastrointestinal safety was completed and unblinded. So when the study is unblinded, when this study was unblinded, Merck's president of research got the data and saw the data from the study. He was the first Merck employee to see the data. And he wrote this email based on what he saw of the data. And the print is small, but I'll highlight the important sections of this email. So he's writing to Deborah Shapiro and Elise Reisen. They're both high-ranking scientists in Merck. And Alan Nice is the vice president of Merck Research. And it's from Edward Skolnick, who's the president of Merck Research. And it's written on March 9th, 2000, the day that the Vigor trial was unblinded. He says here in this text, the cardiovascular events are clearly there. This is real. He's not hiding it. He's being honest. He says it's a shame, but it's a low incidence, and it's mechanism-based as we worried it was, meaning the physiological mechanism of creating an anti-inflammatory drug that would be less likely to cause serious gastrointestinal problems. Could, he is saying, they were aware, and they were aware as early as 1996, I think, that by making it less likely, making a drug less likely to cause GI problems, it might increase the clotability of the blood and increase the risk of cardiovascular problems. That's what he's saying. They knew it. They were looking for it. He says this class of drugs, meaning the anti-inflammatory drugs that were supposed to be gentler on the stomach, called cyclooxygenase 2 inhibitors, selective inhibitors, or COX-2 selective inhibitors. He says this class will do well, and so will we. Now, this is the heart of the dragon. This is a high-ranking executive, the president of Merck Research Labs, is saying that the class of drugs will do well, meaning financially, and we will do well, meaning financially. Now, what that means is that the executives in the drug companies, a large part of their remuneration comes from stock options and stock grants. So what this reflects is the culture of the top level of executives at Merck and all the other drug companies as well, who are so integrated into this culture of maximizing their remuneration through their stock options, that he is saying the class will do well, and so will we. He's saying that we're not going to be slowed down in our financial gain by the fact that the CV events are real and clearly there. Now remember, this is about a 17-year-old girl who died of a massive brain hemorrhage that was almost certainly due to Vioxx. So how did Merck, from the president of Merck Research saying these things, publish an article that didn't sink Vioxx sales? So the article was published, the study was written up and submitted to the New England Journal, peer-reviewed, and published November 23rd, 2000. So was that 6 months after March or something like that when he looked at the data? And the bottom line of the article says, comparison of upper gastrointestinal toxicity of Vioxx and naproxen in patients with rheumatoid arthritis. And the conclusion of the article is, in patients with rheumatoid arthritis, treatment with Vioxx, a selective inhibitor of cyclooxygenase 2, is associated with significantly fewer clinically important upper GI events than treatment with naproxen, a non-selective inhibitor. And that's where it was left. The article did not report the increase in cardiovascular events in the people, the higher rate of cardiovascular events in the people who took Vioxx. It was a pre-specified endpoint. The president of Merck Research knew about it within hours of the data being unblinded on March 9th, 2000. And the New England Journal article didn't even report it. Now this is where my career as a pharmaceutical critic began, on this table, because there was a footnote in an article in JAMA, Journal of the American Medical Association, that led to the documents that Merck had submitted to the FDA to be presented at its advisory committee meeting in February of 2001. And this was in the FDA's cardiovascular review of the VIGOR database. So this is the summary of confirmed adjudicated thrombotic cardiovascular serious adverse events, heart attacks, blood clots, and strokes that were serious enough to land somebody in the hospital. And they did all thrombotic events, which was a pre-specified endpoint, Vioxx and naproxen. And what Merck reported to the FDA was that the people who took naproxen had only 42% as much risk of having a cardiovascular event as the people who took Vioxx. Now, this was a clever manipulation because Merck tried to argue to the FDA that it wasn't Vioxx that increased the risk of cardiovascular events. It was naproxen that decreased the risk of cardiovascular events. The FDA threw it out immediately, said there's no logic behind this, there's no evidence to support it. And in fact, what they turned to immediately was doing the inverse of the 0.42 relative risk, and they did 1 over 0.42. And in the FDA's reports, they said the relative risk of a serious cardiovascular event with Vioxx instead of naproxen is 2.38. The risk of a serious cardiovascular event is more than doubled. Now remember, this sounds geeky, It's in the weeds. I enjoy being in the weeds, I confess. But remember, this 17-year-old girl died, and she was one of 50,000 people who died from taking Vioxx. So what's in the weeds here is really important. And most important, cardiovascular events more than doubling is critically important. Had that been properly reported in the New England Journal article, it probably would have been the end of the drug. And had the New England Journal demanded the data from Merck, that this data that you're looking at right now, it probably would have been the end of the drug, because Merck would have been so liable, they would have understood their liability. But the real result that we need to know is from the FDA's statistical review of the VIGOR trial, because the claim that Merck was making is that Vioxx is safer than other drugs. That's why you should use it. There was never a claim that it was a more potent pain reliever or arthritis medication. The studies showed that it's as good as the other drugs, but it's not better. So the only reason for taking Vioxx was that it's safer. So now we go to all serious clinical adverse events. So all the adverse events that occurred in the VIGOR trial that were serious enough to land somebody in the hospital. And we find that there's a 21% increase. Merck is marketing the drug because they're claiming it's safer because it causes fewer GI problems. There's a 21% increase in the risk of serious adverse events, and that's highly statistically significant. And if you take the rates, here are the rates per 100 people. The rates of serious adverse events. And if you subtract 14.48, which is the rate for people, if you take 14.48, the rate for people who took Vioxx, and subtract the rate for people who took naproxen, and you divide the result of that into 100, because it's rates per 100 patients, you find the number of people that you have to treat each year in order to cause one person to have a serious enough side effect to end up in the hospital. And what this table shows you when you do the arithmetic that I've done is that out of every 40 people who good doctors practicing evidence-based medicine, reading the New England Journal, for those doctors prescribing Vioxx to their patients instead of standard non-selective anti-inflammatory drugs, because they believe it's safer, for every 40 people that's treated with Vioxx, one was harmed enough to warrant hospitalization. This is an enormously dangerous drug. I mean, you've got to treat 100 to 140 people for 5 years to prevent a single cardiovascular event with a statin in order to prevent one non-fatal heart attack or stroke. And here we see the number needed to harm is 40. So good doctors thinking that they're taking the best care of their patients because they're providing the latest evidence-based medicine were actually harming their patients. And that's exactly what happened to our patient Stacy, who had some head trauma and it didn't respond to non-selective anti-inflammatory drug. So the doctor, out of the kindness of his heart, gave her 8 Vioxx tablets that the Merck representative had left in his office to treat Stacy with the Vioxx to see if she would get better, and she was dead within 2 weeks. So the bottom line here is that 86% of clinical trials are now commercially funded. 97% of the most frequently cited articles are commercially funded. Compared to non-industry sponsored studies, industry sponsored trials have significantly more favorable efficacy results and harm results. And we see the harm results minimized in the VIGOR article, and overall conclusions. The majority of physicians' continuing medical education is funded by industry, and 59% of the authors of expert guidelines have financial ties to an interested manufacturer. So everywhere the doctors turn for information, for scientific evidence, to inform themselves, to keep themselves up to date about how to practice evidence-based medicine, is infiltrated by industry. How do we fix this? And I do want to say that I believe this is the core problem in American healthcare. This is why our system has evolved to spending an extra $2 trillion a year and suffering over 1 million excess deaths of Americans each year. It's that our system has been transformed from one that is marketing health, public health, to one that is marketing private profits for the executives and investors in the drug companies. So how do we fix this problem? It's a complicated problem. It's not simple. How do we fix it? So let's look at the dimensions of what would be involved with healthcare reform. We look at it from the point of view of our personal health and our family's health, and from the point of view of getting adequate and epidemiologically balanced and accurate and complete information to healthcare professionals, like didn't happen in the New England Journal's article of the Vigor trial. We look at the effect that this has had on medical schools and academic medical centers, as Harvard University President Derek Bok worried about, at the oversight of the integrity and epidemiological balance of the medical research agenda. We need to look at the lack of data transparency and peer review and clinical practice guidelines. We need to look at the lack of health technology assessment in the United States that doctors in the other wealthy countries can turn to sort through what is presented to them for its commercial value, including what's in medical journals, and to be able to separate the commercial message from the health message. And without a independent health technology assessment, American doctors can't do that. We look for legislative reform, especially campaign finance reform and Citizens United reform. Now, that's a hard ask. It's pretty unlikely that that's going to happen. So whatever happens is going to unfold in the context of unlimited amounts of money coming from the wealthiest entities, which happen to be the drug companies at this point. And that's part of our life going forward, which makes us think that maybe we need a federal healthcare board like the Federal Reserve to oversee the public's interest in the commercial activity of healthcare. So, on a personal and family health, from a personal and family health perspective, we look at the determinants of health, the health information milieu, and working with your doctor. So when we look at population health, what determines the health of the population? 20% of our health is due to access to quality medical care. Other data shows it's between 10 and 20%, so 20% would be a ceiling. And in that 20% is standard care. That's not 20% of our health is due to access to the latest, most expensive developments in biotechnology. 20% of our health is determined by our access to all of medical care, and only a very small percentage of that has to do with the access to expensive biotech developments, which is what's driving up our medical costs. 20%. And the other 80% is due to the social determinants of health. And this is 30% to our health behaviors, tobacco use, diet and exercise, alcohol use, unsafe sex, 40% to socioeconomic factors, education, employment, income, family and social support, community safety. Jobs would be included there as well, the quality of the air, and then 10% to the physical environment, environmental quality, and the built environment. So we are spending, remember the article about the anatomy of healthcare research, we are spending 96% of our research money on much less than 20% of the problem. And that's how we get to the point of wasting $2 trillion a year and having a less effective healthcare system. This, I'll explain this. This sort of shows how this is happening in the real world. And this is a chart where on the vertical axis, we have expenditures, and this is both social service expenditures and healthcare expenditures. as individually and totaled up top as a percentage of each nation's gross domestic product. And so the percentage of GDP on this side, and we have the countries on this side, and then we have the results for each country. So we'll see in the median, the average OECD country is spending 26.3% of its GDP on the combination of health and social services. But that breakdown is much more on social services, 16.9%, compared to health services. So the average countries, which we're doing much worse than in cost and in health, are spending about 1.8 times as much on social services as they are in healthcare services. But in the United States, it's the reverse. We're spending more on healthcare services. This data, it's maybe 2005. We're spending 16% of our GDP on healthcare services and 13% on social services. So whereas the average country is spending 1.8 times more on social services than healthcare services, we're spending 0.8 times as much on social services as healthcare services. Now, the folks who wrote that article pointed out this difference that we're spending, the other countries are spending 1.8 times more on social services than healthcare services, and we're spending about half as much. Now, this is a quote from the article. The ratio of social to health expenditures adjusted for GDP per capita was significantly associated with greater life expectancy, lower infant mortality. And let me interrupt myself and say the ratio of social and health expenditures, independent of how much they're spending, it's just the ratio of expenditures, of social and medical expenditures, was associated with higher spending for social services, was associated with greater life expectancy, lower infant mortality, and fewer potential years of life lost, although it was significantly associated with increases in low birth weight. Now, that may be due to infertility treatments. Bottom line from the authors who wrote this article is that, our findings suggest that the paradox of high health spending without improved health outcomes, that's the situation we're in, within OECD countries may be informed by differences in the spending on social services areas. Reforms that target only health expenditures may miss this important opportunities, So what they're saying is that if we maintain as we go through health reform, the same ratio of social service spending to healthcare spending, we're likely not to get good results. And this is, in fact, what has happened. When Obamacare, which was passed in 2010, when it was implemented in 2014, what we saw is that the number of uninsured Americans went down dramatically from 48 million to 30 million uninsured Americans. And the economy was expanding and the poverty rate was decreasing. So you would think that our health would get better. But those are the years that I spoke about before, where the healthy life expectancy in the United States went down more than any other countries, except for Venezuela, Syria, and got the other one. We'll talk about that. Yemen. So in the United States, we did what we thought was necessary to improve health outcomes by passing Obamacare and giving first-class access to many people who couldn't afford it, but it didn't help. So what role are medical schools and academic medical centers playing? Has their mission been compromised? And I just want to remind you of President Bach's statement that he had an uneasy sense that programs to exploit technological development are likely to confuse the university's central commitment to the pursuit of knowledge. Now, that was in 1981. Now, look how romantic President Bach's statement now is in retrospect compared to what's going on at Harvard Medical School now. Now we've got the Blavatnik Institute at Harvard Medical School. Mr. Blavatnik is a very wealthy, formerly Russian citizen who made a lot of money with the privatization of the aluminum mines in Russia. And he has become a philanthropist, and he generously gave $200 million to the Harvard Medical School. $200 million to the Harvard Medical School, largest grant they've ever had. So this is from the Harvard Medical School website. I've not edited this at all. Led by Harvard Medical School.
Bear with us one moment.
Yeah, excuse us, everybody. We're just having a little technical difficulty here. Be right back. And while we're waiting for Dr. Abramson to rejoin us, we hope that you guys are taking all this information in. I think it obviously gets to the heart of perhaps why we have the medical results that we have. So we're working to get him back on. And it looks like he rejoined us. Great. Thank you so much, Dr. Abramson. You have to reshare your screen.
Okay, sorry.
No worries.
Is that it? We got it?
You're good.
Good. Okay, thanks. I'm sorry. I hit the wrong button. But it added drama to the point that Derek Bach's nightmare about universities getting distorted, the research commitment of universities getting distorted to commercially beneficial discoveries as opposed to public health beneficial discoveries. And the $200 million that was donated to Harvard Medical School is going to be used only for fundamental translational biomedical research. So that's how far we've come. Now, the universities are money-making machines because of the Bayh-Dole Act that we talked about earlier. The universities and their researchers can keep the money. And Mr. Blavatnik, or Sir Leonard Blavatnik, because he was knighted in the UK, is an investor. I don't know to what extent he's investing in the discoveries from Harvard, but there was an article on the front page of the Yale University newspaper that showed that one of the contracts that was funded through the Blavatnik's philanthropy, one of the contracts had written in it that Mr. Blavatnik had first crack at the investment opportunities that were developed based on the financial support by him, that he could be an early investor in the biotech discoveries. So we're becoming biotech discovery machines, not universities that oversee the health and well-being of the public. Medical journals. Lack of transparent peer review compromises their fundamental mission. Let me tell you something that is a well-kept secret. The most prestigious medical journals, large, if not largest, support of financial income comes from their sale of reprints of the articles that they publish back to the manufacturers of the drugs that the articles are about. So the manufacturers can give the drugs to their drug reps to present to the physicians with the imprimatur of the journal on them. In 2005, 41% of the Lancet, it's a journal in the UK, 41% of the Lancet's revenues came from selling reprints. And in the case, the New England Journal did not reveal its data. But in the case of the Vigor article that we talked about, where there was no reporting of the more than doubling the risk of cardiovascular events, serious cardiovascular events, or the harm, the significant harm that's done to 1 out of 40 people who takes Vioxx instead of a non-selective anti-inflammatory drug. The New England Journal or Merck bought 929,000 reprints of that article for upwards of $1 million to hand out to have their drug reps hand out to the doctors they call on. Now, the New England Journal could have known within 3 months, and certainly knew within 6 months of publication of that article, that Merck had deceived them by leaving out the cardiovascular problems that Vioxx caused. The New England Journal knew that, and didn't stop publishing, didn't stop selling reprints. So the JAMA tried.
Okay, it looks like he froze again. John, if you could take a look into this. Again, it looks like we have another technical glitch here with Dr. Abramson. So bear with us while we get that resolved. So we're working here in the background to see if we can get that resolved. All right, and Dr. Abramson should be right back with us. He, I guess he's having some technical issues on his end, and we're bringing him back in. There he is. All right. You know, when that happens to you, Dr. Abramson, everyone thinks, you know, so someone's invading the conference to block you from speaking. I think you might be muted because I can't hear you.
Am I
There you
muted
go.
now?
You're good.
Okay, now to
And-
share screen again.
Yeah, you need to share it again, and I'll confirm with you that it's shared properly.
Okay.
Uh,
What makes you think that that's not the case, Michael?
well, I don't know. I don't know. All right.
Anyway,
Thanks.
that was sort of inhuman. Anyway, I'm walking out of this medical meeting with this high-ranking but not chief editor of a very prominent medical journal, and I asked him, "Why don't you just require that the clinical study report be submitted? It's already produced. It's not going to cost any money. If there's any secrets about manufacturing anything, you can redact that, and then your peer reviewers could look at the real data." And before we took the next step together as we were walking out of this meeting, he said it would be a death spiral for the journal. And what he meant is exactly what's on this slide, that JAMA did that. They went a step further than the clinical study report. They said the actual data has to be reviewed. But what happened is that the large clinical trials stopped being submitted to JAMA, and they went to the number of trials that were submitted to the Lancet and the New England Journal increased proportionately. And any trial that does this, any journal that requires data to be submitted on their own is going to voluntarily enter a death spiral, because the big articles that sell reprints and make money and create an impact factor aren't going to come their way. So there was a movement afoot after the JAMA changed its policy to have all the journals work in consort to require data transparency so that no individual journal that decided to do the right thing would be hurt. And unfortunately, the oops, the result of that, written up in stat, was that the fruit that was born was like that ice cream cone, which was in the article. New science data sharing rules are 2 scoops of disappointment. And what they mean is, I put the language from the article there, but what it means is not only did the International Committee of Medical Journal editors, 13 editors of the major general medical journals in the world, not only did they not require data transparency, but they kicked the ball down the ball so far down the field that all they require is a statement about what they're going to share. So, for example, in the article they published about the Alzheimer's drug Leqembi, which we don't have time to talk about today, but looks like it produces a statistically significant slowing of early Alzheimer's, but not a clinically significant slowing of early Alzheimer's. And if you want to know more about that, we can talk about it in the questions. But when you look at the New England Journal of Medicine's website, they published the article that said there's a statistically significant slowing of Alzheimer's disease. And you go into the bowels of that article and look at the supplemental data and look at the data sharing agreement. They stated what their data sharing policy will be. They won't share data. And that fulfilled the requirement that the International Committee of Medical Journal editors implemented to state your data sharing policies. Now we get to clinical practice guidelines. These doctors have to follow clinical practice guidelines. It's supposed to be the best evidence-based medicine. And if they don't follow those guidelines, the guidelines are presentable in malpractice cases. But they have no access to the guidelines also, like the peer reviewers for the medical journals. They have no access to patient level data and they have financial conflicts of interest. So the Institute of Medicine was noting that these financial conflicts of interest couldn't be stamped out. And they had written for about 20 years that something needed to be done about it. And finally, the Institute of Medicine made a recommendation to the National Guideline Clearinghouse indicating the extent of adherence. The Institute of Medicine called for a statement indicating the extent of adherence to the guidelines for guidelines. The Agency for Healthcare Research and Quality, which is in the federal government, should require the National Guideline Clearinghouse, which was the go-to site for clinical practice guidelines. They were getting 200,000 hits a month, to provide a clear indication of the extent to which clinical practice guidelines submitted adhere to the standards of trustworthiness. And when will the National Guideline Clearinghouse implement this? In October of 2017. So this is a major step forward for doctors to be able to go to the National Guideline Clearinghouse and to get not only the guideline, but an independent assessment of how trustworthy the guideline is based on their adherence to the guidelines for guidelines. But this appeared above that statement soon thereafter. And it's the Agency for Healthcare Research and Quality National Guideline Clearinghouse website. It's going to be implemented in October 2007. The website will not be available after July 16th, 2018, because federal funding through the AHRQ will no longer be available. In other words, the AHRQ and the National Guideline Clearinghouse was going to take this matter into its own hands and require a statement of trustworthiness that would warn doctors or inform doctors about the trustworthiness of guidelines, and it was zero funded. The government zero funded it, and doctors do not have access to that website or to the independent oversight of it. Now, controlling the U.S. is controlling the price of drugs. We are alone in allowing drug makers unlimited opportunity to exploit their monopolies on new drugs. Let me explain that a little bit. A monopoly is the monopolies they have is the result of the patents that they are granted. When they get a patent, it usually provides at least 9 years for regular drugs and 13 years for biotech drugs, where the drug company alone can market the drug under the brand name of the new drug. So when they have a new drug that they claim that virtually all of the new drugs have unique benefits, although we just saw that only 25% do, but their marketing pays off because when they market the brand name of their drug, that's their drug. They have a monopoly on it. And as you all are probably aware, there's a new plan in the Inflation Reduction Act from President Biden that forces the drug companies to negotiate a limited number of drug prices for Medicare payment. And this is an article that appeared a month ago in the Washington Post, how Big Pharma is fighting Biden's program to lower seniors' drug costs. So the drug industry has dug in, and they're going to try to undo the progress that's been made in controlling the drug prices, even in a limited fashion. So in a flurry of lawsuits, these drug makers have blasted the government initiative as unconstitutional, defending their pricing practices, and warned that regulation could undermine future cares. Remember that. They've said it a different way. They said it's going to be a nuclear winter for drug development, even as millions of older Americans say they are struggling to afford their essential treatments. This program this is a lawyer for Janssen. This program would have a debilitating effect on plaintiffs' ability to compete, and innovate, said Kevin King, a lawyer for Janssen, which makes Xarelto an anti-blood clot medicine, which is subject to negotiation. So they're crying like stuck pigs that they're not going to be able to develop new drugs, and that the curtailment of their profitability is going to be a disaster for American healthcare. Now, the CBO is the Congressional Budget Office, and they are an extremely trustworthy organization whose job it is to take new legislation and calculate what the consequences of the new legislation will be. So the drug industry says it's going to curtail their drug development and it's going to curtail availability of new drugs. The CBO estimated that negotiations will reduce the deficit by $25 billion in 2031 through decreasing the cost for Medicare Part D, Medicare Part B in a hospital and doctor's office, administration of drugs, and other federal funding. $25 billion in 2031. In 2031, a guesstimate of what the drug costs will be is $900 billion. So what the drug industry stands to lose is 25 billion out of 900 billion. That's 0.25%. It's minuscule. And the CBO estimated that over the next 30 years, 13 fewer drugs of 13,000 estimated new drugs will come to market as a result of the law. 13 fewer new drugs. But remember, only 1 out of 4 new drugs is actually materially better than therapies that are on the market already. So we're talking about not having access to 3 new drugs over 30 years in order to do limited negotiations with the drug companies. And it's important to keep in mind, this is a really important case in point, because the drug company's job is to maximize their profits. It's not to maximize their profits while they optimize Americans' health. It's to maximize their profits. And if they're going to lose $25 billion in 2031 because of this legislation, even though that's a drop in the bucket, and there are going to be 3 fewer new drugs over 30 years, they're going to fight it. They're going to dig trenches and try and prevent that healthcare reform from coming forward. So as you read as you hear about the pharmaceutical industry complaining that they're being treated unfairly and unconstitutionally, and this is a Robin Hood project that takes from the rich and gives to the poor, it's nonsense. It's their defense that they've mounted to preserve every dime that they can currently make. And one of the biggest reasons that we are unable to solve this problem is because from the 2020 election cycle, 2/3 of our legislators receive money from the drug companies. And it's fairly evenly divided between Republicans and Democrats. This is not a partisan issue. The Republicans and Democrats take money from the drug industry and are influenced by money from the drug industry. So to wrap up here, how do we go forward? The first step is to accept pharma's true role in society. If we spend our time complaining about pharma being pharma being greedy, or pharma not being a good citizen, we're wasting our time. Their job is to maximize their profits. And complaining that they're greedy is like complaining that leopards have spots. That's who they are. That's what they do. That's their mission in society. So we've got to understand that that's their mission. It is their mission. It's not going to change. They're not going to have some kind of spiritual revelation where they should be public health minded, not profit minded. It's not going to change. So what we need is guardrails on what their primary mission is. Without guardrails, we're not going to get anywhere. But here's the problem. Pharma has relationships with the medical journals. We talked about buying the reprints with nonprofit organizations like the Alzheimer's organization touting Leqembi, the new drug that was approved last year for Alzheimer's disease, or statins, or expensive insulins with the American Diabetes Association. Pharma has ties with the drug advocacy groups. So when you hear the Alzheimer's organization is recommending that people get examined by their doctors for early Alzheimer's so they can be treated with this new drug Leqembi, which is certainly of questionable value. The Alzheimer's organization is getting money from pharma, and they're influencing the guidelines. And they now pay 65% of the budget of the FDA is now paid for by pharma in the prescription drug user fee agreement. And the academic medical centers and the researchers are dependent on pharma money for research money. So what we've got is a classic market failure in the development and dissemination of our healthcare, air quotes, knowledge. And a market failure, market failure is a stable situation, because each of the two parties in each of these relationships is making money. So they don't want to give up their advantageous relationships. For a market failure, you need outside government to intervene. And yet we have no way of doing that. We don't have a federal health board that can intervene. So if healthcare is going to be successful, it's got to include restoring epidemiological balance to medical research. That's number one, because if we want to prevent heart disease, 80% of our efficacy is going to be in changing lifestyles, and no more than 20%, and we can talk about it, but much less than 20%, in my opinion, is due to medical therapy. It must include ensuring the accuracy and completeness of the evidence base in clinical care, which requires transparent review of articles and transparent review of guidelines. Guidelines have to have the patient care data, the raw data. It involves implementing a health technology agency, because American doctors are trying to, when they try to decide which drugs are best for their patients, they're essentially playing pin the tail on the donkey. It's the articles that are published that have not been transparently peer reviewed. It's the marketing that goes on. It's the collection of the articles into clinical guidelines that inform the doctors, but none of it's based on an independent analysis of the actual research. And then the final thing is control of the price of drugs. And again, we need to control the price of drugs because we're just spending too damn much money. But that's not the big issue. The big issue is that the excessive profitability of the drugs creates this marketing, fuels this marketing machine that creates the use of expensive drugs in the United States at such a higher rate than in the other countries. And then finally, to achieve meaningful reform, we need to require that doctors have adequate information and that doctors acknowledge that they don't now and that they can't function as learned intermediaries. That's a big ask for doctors to acknowledge that, but it's time to do that. And I would hope that any doctors listening would read my recent book, Sickening, and that you folks, non-doctors who are listening to this, loan your doctors a copy of the book because they don't understand. They're not acting. I've seen a doctor act in bad faith, but very few are acting in bad faith. They're acting in compliance with what they've been taught good doctors do, and they don't understand because the data is not accessible to them. It's only accessible in court, and it rarely leaks out of court. They don't understand that they're being hoodwinked, and they've got to understand that if there's going to be any change. So true reform is going to require a coalition that includes the public, and that's you, healthcare professionals, and businesses that purchase health insurance for their employees. None of these reforms can happen until the political influence of the manufacturer's financial resources is controlled, is curtailed, and until the coalition of healthcare professionals, government officials, and most importantly, the public understand that coming together into a coalition to straighten out our healthcare is the only way that we can make progress. And that coalition has to become more powerful than the power and money of the drug industries. Now, you may say that's wishful thinking, and it is, but it did happen in the United States in the post-World War II years when we were growing economically, when the fruits of that growth were distributed equally to working class people and upper middle class people and the wealthy. And John Kenneth Galbraith said so poetically that there were countervailing forces that controlled the tendencies of big business to exploit their power. And the countervailing forces at that point were unions and government. Now, we have little faith in government, and the unions have been weakened. But there was a time, it was a golden era of capitalism in the United States, the 3 decades or so after World War II, where the economy grew and all Americans benefited. There was racial discrimination, there was sexual discrimination, but everybody benefited. But it's going to take all of us who understand these problems to become activists so that there is a big enough countervailing force to curtail the natural tendencies, profit-seeking tendencies of the drug companies. Now, I want to finish with a little ancient history. This is the crest of the Royal Society of London. It was adopted in 1662. This is 30 years after Galileo was sentenced to life imprisonment. It was home incarceration, but life imprisonment for writing a book that showed, by using a new scientific tool, the telescope, that the Earth was not the center of the universe. And for this, the church sentenced him to incarceration for the rest of his life. A mere 30 years later, the Royal Society was formed in London and formed by the scientists who were now doing real science without the fetters of the church telling them what they could and couldn't do. And Robert Boyle was one of the leading scientists. He developed the scientific analysis of the pressure that's generated when water boils and is turned into steam, and that became the steam engine. Soon thereafter, Isaac Newton became a member of the Royal Society. But the reason why I bring this up is because that crest says nullius in verba. And nullius in verba means take nobody's word for it. In other words, they would not be subject to the authority of the church. They would only be subject to the principles of good science. But here we are, almost 4 centuries later, and we have reverted so that now our so-called science is subject to the authority of the financial markets and not to the authority of good independent science. And this is what we have to regain if we're going to fix American healthcare. So I thank you very much for your attention, and I look forward to your questions.
Great. Thank you so much. So actually, I wish I had more time with you because it's a lot of really great information. So we've got about 12 minutes or so. If you'd like to ask a question, if we do have time, although it's very limited, you can raise your hand in Zoom. So to get right into it, so for Dr. Oh, actually, real quickly, because I think this is very important. How can people follow you and keep up to date on your current work?
I am social media phobic. I apologize.
No,
I've said what I have to say in sickening. If you want to understand this stuff, this is just scratching the surface of the problem. I spent 6 years writing sickening. I dropped out of litigation because money was changing hands, but we weren't getting any closer to the real truth of this coming out. I spent 6 years writing sickening. It's a thorough analysis of what's going on, and it's written for non-medical people. It's also written for medical people. There's plenty of references, but that's how to find out what's going on. Now, I'll answer my emails. You can email me at johnabramsonmd@gmail.com. And if you have a question, just email me and I will respond.
All right, great. Thank you. And is anyone else taking up this mantle and doing work like this?
Yes, that's a great question. Yes, there are people. There are a number of people, but the problem is that the mainstream media there's an iron curtain that's come down in the mainstream media. So the first book I published in 2004, I did all sorts of TV appearances and radio appearances and op-eds and magazines and so forth. There's been almost nothing after this. The pharma has gotten its feet underneath itself, and it has prevented it's like a chain reaction can't get going. It's like this information, when people hear it, they get excited. When I lecture to doctors at Grand Rounds in Chapel Hill or Sloan Kettering Division of Ethics, people get excited about this. But once they walk out their door, they walk into the regular world because the media won't cover it. So it doesn't seem to be legitimate. So what we've got to do, and if anyone has any ideas, I am open. What we've got to do is get this information out to the public so that the discussion can start and a chain reaction can start about how the American people are being wronged by the rampant commercialism in the medical knowledge that doctors rely on. Without that chain reaction, nothing can happen.
And how does the impact of having commercials air on the major cable stations for these pharmaceutical drugs impact their coverage of issues like this and the dangers of these pharmaceutical drugs?
Right. So I have been told, I can't quote the source and I can't verify it, but I was told by a major network health director that the unspoken rule was that there will be no criticism of pharma on any segment of TV that's bounded by a drug ad. And I believe that half of what's going with those drug ads is so that pharma has swept criticism out of the media. It also creates a tremendous distortion because those drug ads, they don't tell you how many people have to be treated in order for one to improve, what alternative methods of therapy, pharmaceutical or non-pharmaceutical, how alternative methods compare to the drug they're advertising. They don't tell you the real cost. I think it's a sin to put in an ad that copay may be $0 or $5 when the cost to society may be $1,000 or $2,000 or $10,000 per month. So the drug ads are here to stay. I've been told by honorable lawyers that they're a manifestation of our First Amendment right of free speech. And I can believe that. Drugs have a useful purpose. It's not like cigarettes that don't have a useful purpose. They have a useful purpose, but it's within the ability of the FDA and the Congress to set rules that make that advertising truly educational. How many people do you have to treat in order for one to get better? How many people do you have to treat to harm one? What's the real cost to society? What's the benefit of lifestyle changes? What's the benefit of less expensive older therapies? If they would do that and take the dogs and frisbees and babies out of it, then the advertising could actually serve a useful purpose.
And is there any non-governmental body that is trying to, whether in the United States or outside of the United States, that trying to aggregate that information of what, older drugs are as or more efficacious and anything like that?
Yes, in the other wealthy countries, there's health technology assessment. We have an organization called ICER, which is not governmental, which has participation of people who have financial ties to the drug companies, that does cost effectiveness research. But for example, for Trikafta, the cystic fibrosis drug, that is costs $322,000 per year, and the FDA label says that its benefit is limited to 14% improvement in lung function for people with cystic fibrosis, and one infection that doesn't happen every 3 years in people with cystic fibrosis. And for that, the drug company charges $322,000. So that was evaluated by ICER, and ICER said, I think, I'm not positive this is exactly right, but I think they said you need to cut the cost by three quarters, down to $80,000 or so. Now, that seems like a radical proposal, but the two people who reviewed that, or two of the people who reviewed that, were both financially tied to the manufacturer of the drug. So supposedly we have that function being done in the United States, but it's not being done independent of the drug companies. We need that.
Great, thank you. And for well-meaning medical professionals who do look to these journals to try to find out what's going on in their field, and therefore, make medical decisions that are actually beneficial for their patients, what strategies would you suggest that these healthcare professionals do to stay informed about the genuine efficacy and safety of medications beyond what the pharmaceutical companies communicate to them?
That's an excellent question. It's a little complicated, and I would be happy if medical professionals want to talk to me about this, if we could get a group together. But there are FDA documents and the FDA label that does provide more information about the drugs than is in the medical journals. For example, in the Paxlovid label, the drug for COVID that supposedly shortens the duration of COVID.
John, I think oh, there we go. You froze for a second. Go ahead.
I'm sorry. The FDA documents show that people who have been vaccinated and or have had COVID will shorten their clinical symptoms of COVID from 14.1 days to 13.8 days, meaning minuscule. But it's hard to get that information. So if you go to the drug label and the FDA documents, you can see that. Now that requires some degree of working together in a workshop, which I would be happy to do. If professionals would like to do that on the web, I would be happy to do that. So there is more information, but it's hard to get to without training, specific training on accessing.
So last year we had a speaker on who one of the things that they do is their organization reads all the peer-reviewed journals in the English language, and then they aggregate it and they make content for it that is accessible to the general public, and the individual's quite popular. And during the Q&A last year, I'd asked him about your work, suggesting that this was a problem, and that and correct me if I'm wrong, and I don't think you tackled it in this year's presentation, that the peer reviewers of the medical journals, or the articles in medical journals, don't necessarily get the underlying information. They just get like the study design and the conclusion, and that's all they're really reviewing. Is that true?
That's true, except take out the necessarily. They don't get it.
Okay. And then so I brought this up to this individual, and they said that, oh, it's getting so much better that the journals are really starting to get the information, the information that these studies were actually based on. Do you find that to be changing in any way, shape, or form, or is that statement?
It's changing, but it's changing so slowly and getting to a material difference in the quality of the information so slowly that I think it's doing more harm than good, because the docs, well-meaning docs like the doc you're referring to, believes it's getting better, but we're not getting the data. The data aren't there. If it's going to make a difference, it's pretty simple. The peer reviewers need to have independent analysis of the full data set, and the data need to be transparent at the time that fully transparent at the time the journal article is published. That's transparency. They're going to do baby steps up to that would take 1,000,000 years to get to full transparency. So in a formal sense, he's right, they're making progress. In a functional sense, it's not making any difference. And when people make those claims, I'm sure that the doc you were talking to is talking in good faith, but what they're doing is actually providing cover for the lack of progress of true functional transparency.
So we have about 2 minutes left, maybe a little bit less. So I'm going to ask you two quick questions related to each other. One is the awareness of this issue growing? And is there anything that's going on that leaves you optimistic about things to come with regard to these issues?
That's a great question. And this is the craziest thing that I don't understand. I've been completely blackballed by the liberal media, complete. Right-wing media is interested in what I have to say. And I've been invited twice by Hillsdale College, everybody will groan and boo, to speak at health forums. And they have been completely interested. They transcribed one of my talks. They sent it out to 6 million families. And the right is concerned about the public not being served by the commercial takeover of our medical knowledge. And the left doesn't want to talk about it. If anyone can explain this to me, please send me an email.
Well, I will say that I have found the last few years very confusing as far as where my views, which have remained unchanged, have ended up on the so-called spectrum where,
Exactly.
So I won't get into politics per se, but it has become very confusing. But I think get the message out wherever you can. So that can, well, anything that leaves you optimistic, is that what leaves you optimistic? Is that some people are trying to listen to you?
Yeah, it's hard to feel optimistic about the right edge of politics carrying us to the promised land, but sorry to be partisan, but what does discussions like this in public, posting this on YouTube, at some point, we've got to hope that it will create a critical mass and that chain reaction will start. That's the only hope. And that everybody who understands this, talk to your family, talk to your doctor, make this conversation polite and not a wacko conspiracy theory. We've got to normalize this conversation. And that's very hard to do for non-professionals, for non-full-time pharma critics, because they're so good at obfuscating the truth. And like the doc who in good faith said to you, look, we're collating a lot of information and transparency is getting better. That's in my opinion, that public statement takes us in the wrong direction, because it's harder to understand once people believe that. It's harder to understand how impossible it is for doctors to get transparent information.
Well, we're out of time, so I want to thank you. I want to say that as far as sounding effective and not sounding, out there, which a lot of times this type of stuff can sound, you do a phenomenal job, and you going out there and speaking on this gives me a hope and a sense of optimism on this issue. So thank you very much.
Thank you, and thanks for the kind words, and thanks for getting this message out.
Thank you. If we can unmute the audience so they can share their appreciation for Dr. Abramson.
Thank you very much.
Thank you so much.
Thank you, Courage.
I watch your book.